It's the CDS Academy here, and we are back with another topic in clinical medicine, acute gastroenteritis, which is one of the most important topics that have to be known in a pediatric patient, tertiary. So, for us to understand what acute gastroenteritis is, we first need to understand what diarrhea is really. So, diarrhea is the term that is used to just describe an increase in the fluidity, volume, and frequency of stools relative to the usual habit of each individual. So, when we are saying diarrhea, we are talking about the passage of three or more loose or watery stools in 24 hours. Okay, it's important to understand that three or more by definition. So this three or more is telling us about the frequency and of course also the volume, and then the loose or watery stool is telling about the fluidity, and this is happening in 24 hours. We can also talk about it in terms of how much stool someone has lost per body weight. So greater than 10 mils of stool per kg of body weight. All right. So that is basically diarrhea, but the best definition that we talk about is the passage of three or more watery or loose stool in 24 hours. Now, if we say this stool is loose, what do we mean? It means that it can actually take up the shape of a container. That's the meaning of loose stool, and you need to know that loose stool is a stool that can take up the shape of a container. Now, acute diarrhea is the passage of loose or watery stool three or more times in 24 hours for up to 14 days. If we say acute, we are simply saying in the first 2 weeks or for the first 14 days. Okay, someone has been having this diarrhea. All right, so that is what we actually call at gastroenteritis or acute gastroenteritis, AGE, and it's because of an infection. When you look at the normal stool pattern for someone that is for a child between 0 to 4 months, mostly it is actually going to these ones are breastfed. Okay, so for the stool, they'll be able to pass 2 to 4 motion. They'll have a range of motions 2 to 4 per day. Sometimes can go from 1 to 7 that range, and usually this stool is porridgey in consistency with a pH of about 5, a bit or more acidic. And then for those that feed by a bottle, those that are fed using a bottle, their stool might be 2 to 3 times per day, and it can be yellow to light green and firm with a pH of around 7. Starting from 4 months to 1 year, these ones, you can see that the motions actually getting to decrease. 1 to 3 motions per day, the stool is dark yellow, firm, and after 1 year, this stool is actually formed like an adult, and it has got an odor and a color. So the way we classify diarrhea, we can classify it by duration, by consistency, by etiology, and many other factors. So by duration, we have got acute diarrhea, which lasts less than 14 days. Persistent diarrhea, this one starts acutely. Okay, it is infective in nature, meaning that you actually have an infection which starts acutely. Acutely means it starts there and then or within a shortest period of time. But then it tends to last more than 14 days. Okay, started acutely and then it went beyond 14 days. That is persistent diarrhea. So here malnutrition and dehydration can actually occur. And then chronic diarrhea is one that lasts longer than 14 days and is of insidious onset. Okay, it is going to start slow like that. So there's going to be an underlying cause that we can actually identify. For example, malabsorption, inflammatory bowel disease, immunodeficiency, and such. You can also classify diarrhea by the consistency or the type. You have got acute watery diarrhea, basically watery diarrhea, and this is the commonest type of diarrhea that occurs within 24 hours. Okay, the main danger of watery diarrhea is because you are losing a lot of water, so you can have dehydration. There can also be weight loss, also electrolyte imbalance. Okay, the commonest cause of watery diarrhea is actually viruses, and specifically the rotavirus. You need to know the rotavirus is actually the commonest cause of diarrhea altogether in a pediatric patient. Okay, and then you have got bloody diarrhea, which is also known as dysentery, and this is where the stool contains blood, even mucus, and associated with abdominal pain or cramps, Tenesmus, this is where someone feels like passing stool, though when they go to the toilet, really there's nothing coming out. Even fever can be there because there's actually an infection. All right, this is infectious diarrhea, and it suggests that you have actually a pathogen. Usually those that are invasive, they penetrate the GI mucosa, so causing these ulcers that can actually bleed. Okay, for example, Shigella, E. coli, and the Entamoeba histolytica. You can classify diarrhea also by the severity or the frequency of the stool. Mild diarrhea is when someone is having 4 to 6 motions per day. Moderate, 6 to 10 motions per day. Severe diarrhea is where someone has got greater than 10 motions per day. It's very important to understand this also. You can also classify diarrhea by the pathophysiology. You have got secretory diarrhea where there's just excess secretion of electrolytes, and so water also follow those electrolytes. Let's say if electrolytes are being secreted into the GIT, what happens in that case is that water follows, okay, in the lumen of the GIT. For example, what happens in cholera? That's a secretory type of diarrhea. You also have osmotic diarrhea, which is because of poorly absorbed solids. For example, lactose that can't be absorbed and then it starts to pull water from the cells into the lumen of the GIT, causing their diarrhea. You have got exudative diarrhea, which is basically inflammatory damage. Okay, the sometimes we call this as invasive diarrhea because there's actually damage to the wall of the GIT, the epithelium. So there's going to be blood, there's going to be pus, there's going to be mucus. For example, what happens in inflammatory bowel disease, ulcerative colitis, and Crohn's disease, and also in dysentery. There's also the motility-related diarrhea, where they just see altered transit time. There's just a problem with motility, movement in the GIT. Okay, for example, in inflammatory bowel disease, even after surgery. So secretory diarrhea occurs when the intestinal mucosa starts to secrete fluids. It's actually removing fluids. The cells are secreting fluids into the lumen of the GIT. And what can cause this includes inflammation, as in inflammatory bowel disease, even when you have got a chemical stimuli. Okay, secretion is also stimulated by mediators of inflammation and by various hormones, for example, the vasoactive intestinal peptide, okay, and also cholera. What cholera does is that it secretes the enterotoxin or the cholera toxin from this Vibrio cholerae, which is the bacteria. And what is going to happen is that this toxin is going to cause an increase in the levels of cyclic adenosine monophosphate within the epithelial cells of the GIT, which we call the enterocyte. And that will lead to these guys starting to secrete chloride ions, and so water will begin to follow. So you can see this is the cholera toxin. Once it attaches there, it is taken into the cell, and by retrograde transport, what it does is that it will stimulate adenylate cyclase that is gonna uh, activate the convert ATP to CAMP. CAMP is going to lead to the activation of protein kinase A, which is a guy that actually phosphorylates proteins. And so what protein kinase A is going to do is that it's going to go and inhibit the proton pump. This is the sodium hydrogen pump, and then it will stimulate the chloride pump, meaning that sodium can't enter the cell. So sodium is still in the GIT lumen, and then chloride is also going into the GIT lumen because it has been stimulated. The chloride channel has been stimulated. So I've got sodium in the GIT lumen. You are also chloride in the GIT lumen. Where sodium and chloride are, water follows. So water start going that side. It's also to be secreted, and that's how this diarrhea comes about. Osmotic diarrhea is going to happen because of malabsorption of ingested substances. Substances that have been taken in the GIT cannot be absorbed, so they are just in the lumen. So they begin to pour water to themselves, as in lactose. You know that for the absorption of carbohydrates, carbohydrates are only absorbed as monosaccharides. So some people lack the enzyme lactase that breaks this disaccharide lactose. So because you can't break down lactose, you can't absorb a disaccharide, so it will still be in the GIT. And carbohydrates are actually uh, tend to pull water towards themselves. So what happens, that water will be pulled towards this lactose. So that is what we call lactose intolerance, and that's one cause of osmotic diarrhea. You have also generalized maldigestion. Okay, that is in, for example, in someone that has got pancreatic insufficiency or with intestinal injury, even certain non-absorbable laxatives. These are drugs that are given actually, or substances that are given to to cause diarrhea in case someone has got constipation. For example, polyethylene glycol and milk of magnesia also causes osmotic diarrhea. These are actually drugs that can be used in constipation. So that is what happens. So when you look at the difference between osmotic diarrhea and secretory diarrhea, we have got in osmotic, okay, sodium is going to be less than 70. In secretory, sodium is going to be greater than 70 milliequivalents per liter. In other words, in osmotic diarrhea, you're actually losing, okay, sodium. So these are actually in stew, all right? The one where you are losing, so secretory diarrhea, you actually lose sodium. Look at this, okay? Look at the secretory type of diarrhea. Can you see that the sodium is still in the lumen? Because like cholera stops this pump which will be taking sodium into the cell. So sodium is still in the lumen. So in secretory diarrhea, we expect that this sodium is actually going to be found in stew. Okay, that is why in secretory diarrhea, sodium in stew is greater than 70. And then when you look at the stew osmotic gap, which is the sodium plus potassium over 2, it is less than 50 in osmotic, it's greater than 50 in secretory because we've got a lot of sodium in this too. The pH is usually less than 5, meaning that it is more acidic, okay, for the stew in osmotic diarrhea. And what happens in osmotic diarrhea? Remember, you have got sugar in the intestines, and that sugar is going to be fermented by the normal flora, which is in the GIT, and that will lead to the production of acid. That's why the pH is acidic. And then in secretory diarrhea, the pH is greater than 6. It is more alkaline. Actually, when I was having my case at fourth year, I had a case during my OSCE, it was acute gastroenteritis. These are the questions that you are asking me. What do you expect to be the pH in osmotic diarrhea? All right, so just take note of that, and you should be able to have an explanation as to why it is so. So when you look at the volume in secretory diarrhea is really a lot because a lot of substance is actually being secreted plus what has not been absorbed. Okay, in osmotic diarrhea, the volume is not that large, it's less than 200 mils per day. All right, so that is what gets to happen. So please, you need to know these are the three main types of diarrhea: secretory, invasive, osmotic. The invasive is because of four microorganisms actually just entering into the GIT. For example, septicemia, intestinal perforation. Uh, Actually, these will be the complications because when a bacteria enters through the GIT into the cells, it can lead to sepsis. It can lead to perforation, basically forming walls within the GIT. Okay, and it can lead to toxic megacolon and also hemolytic uremic syndrome, which is an important topic also that we have to know. We'll get to discuss it. What are the factors that predispose people to being at risk to getting these diseases or acute gastroenteritis? So there are biological factors that increase susceptibility to acute diarrhea. For example, malnutrition, the age, children are more affected. Failure to get immunized against rota, I'll talk about it later. Failure to of measles vaccination, because measles is again another problem that can actually cause this AGE. Selective IgA deficiency, antibody A deficiency, because this guy is actually present in the GIT, IgA, and also HIV. There are also behavioral factors that increase the risk of acute diarrhea. For example, not breastfeeding exclusively for 6 months. It's very, very important to make sure that the child is breastfed exclusively for the first 6 months. And then after 6 months, you can now add other foods to the feeds that the child is taking beside the breast milk. At 1 year, 6 up to 2 years, you can now actually wean the child. Okay, you can stop breastfeeding them, not really weaning. Weaning is basically introducing other feeds, isn't it? So what is important is that you don't stop breastfeeding this child so early in time. Okay, also using infant feeding bottles, this can predispose them to having infections that can actually lead to acute gastroenteritis. Not washing hands after defecation, handling feces, or before handling food. All right, so it's important to understand that. Now, when it comes to the causes of diarrhea, there are different causes of diarrhea: infectious causes and non-infectious causes. But of course, the commonest causes in acute gastroenteritis, when we are discussing it, we are talking about infectious causes. If for the non-infectious causes, I'm going to bring them under the differentials for AGE, acute gastroenteritis. So the commonest by far cause of acute gastroenteritis is the virus. So viruses account for 70 to 85% of causes in the developed countries, and children who are less than 2 years are the commonest who are affected. And the rotavirus is the commonest cause of acute gastroenteritis en masse. All right, very important to take note of that. So rotavirus, as in our setup in Zambia, you get to be there are three vaccines that are given for rota at 6 weeks. That is the first vaccine that will be given. You repeat it at after 4 weeks later, that means at 10 weeks, and then after 4 weeks again, that means at 14 weeks. So you need to know when the vaccination for rota is given in our setup. You need to know. You cannot discuss diarrhea, AGE, without knowing the vaccination schedule for rota in Zambia. All right, very important at 6 weeks, and then repeat 4 weeks later, which is at 10 weeks. Repeat 4 weeks later again at 14 weeks. So for viral diarrhea, it has got a seasonal variation, and it is higher. The cases are going to be higher in the winter, and they are decreased in the summer. You have got other viruses that can cause acute gastroenteritis, like the Kali C virus, astrovirus, Norwalk virus, adenovirus. Actually, some of them are actually enteric viruses. Okay, not some of them. Most of them are supposed to be enteric viruses. So they're supposed to be enteric viruses because this is diarrhea. It affects the GIT. Okay, respiratory viruses cause problems to the respiratory system. All right, so that is basically that. So for viral diarrhea, the presentation is a child is going to have a low grade fever, pyrexia, less than 38.5. The fever is not that much. It can actually be associated with an upper respiratory tract infection because these viruses can actually also tend to affect the respiratory system. Vomiting is going to be followed by copious watery diarrhea. So usually the diarrhea is here is watery, even up to 10 to 20 bowel movements per day. Okay, now the diarrhea, mostly when we talk about viral diarrhea, it is mild to moderate. Remember when we talked about the classification for mild to moderate, the mild one is 4 to 6 motions per day, moderate 6 to 10 motions per day. So usually you don't go beyond 10 motions per day for viral diarrhea. Okay, it is also transient. So the diarrhea is going to last for 5 to 7 days, and then it's gonna stop. Usually it is watery diarrhea, and it doesn't have a smell. It is odorless. For the bacterial diarrhea, there are different types of bacteria that can cause diarrhea. For example, Campylobacter jejuni, Salmonella, Shigella, E. coli, Yersinia, Clostridia difficile. Now, Clostridia difficile, this one is important for us to know. This guy causes what we call antibiotic associated diarrhea. So someone has been taking antibiotics, more especially penicillins, cephalosporins, clindamycin. So they are taking these antibiotics, and later on they develop diarrhea. We call that as antibiotic associated diarrhea, and is caused by Clostridium difficile. The presentation for bacterial diarrhea, there's going to be a high grade fever, different from the one in viral, and then shaking chills, foul smelling stool. Sometimes it can also be bloody stool, abdominal cramping, and also fecal leukocytes. And then this one is more common in the summer. Okay, there's going to be high fever, which is greater than 38.5 degrees Celsius. Right. Usually here the diarrhea is going to be severe, more than 10 motions in a day. Now for diarrhea caused by bacteria, it can be bloody, watery, and it can start bloody and then turn up, or it can start water and then turn up bloody. So you need to know the causes. So for bloody diarrhea, what are the causes? Salmonella, Shigella dysentery type 1, and then you have got E. coli. Now in E. coli, you have got five strains: entero-invasive, entero-hemorrhagic, and then you have got enteropathogenic, enterotoxigenic, and then enteroaggregative. So the first two, entero-invasive and enterohemorrhagic, these two cause bloody diarrhea. Invasive, it invades the wall of the GIT. That's why it will cause diarrhea, which is bloody. And then hemorrhagic, think of hemorrhage, it's blood, right? So that one also causes bloody diarrhea. The enterohemorrhagic is also known as Shiga toxin producing E. coli because it produces a toxin that is similar to the Shigella toxin. The enteropathogenic, enterotoxigenic, enteroaggregative, those who cause watery diarrhea, those are other strains of E. coli. And of course, now Shigella is put here. This is the diarrheal type. Otherwise, Shigella will cause bloody diarrhea. And then you have got Campylobacter jejuni, which is going to cause watery offensive diarrhea for 2 to 4 days, which later on can become bloody. Therefore, the causes of diarrhea, the bacteria, we call these as we have got the enterobacteriaceae, which are the gram negatives, okay, and the non-enterobacteriaceae, okay, gram negatives. So the enterobacteriaceae associated with the diarrhea, we have got enterotoxigenic E. coli, watery, enteropathogenic E. coli, watery, enteroaggregative E. coli, watery also, enterohemorrhagic E. coli, that is bloody, enteroinvasive E. coli, that is also bloody, salmonella, that is bloody, shigella is bloody, yersinia is also bloody. And then we have got the non-enterobacteriaceae, gram negatives. So I've got Vibrio cholerae, which will cause watery diarrhea. Vibrio parahemolyticus, bloody. Campylobacter is also bloody. All right, so you need to get to take note of that. We also have parasites. Parasites can also cause diarrhea. For example, Giardia lamblia, and then Entamoeba histolytica, Cryptosporidium parvum also. Giardia, the diarrhea that is going to cause is going to be watery and offensive. Usually there is no fever. You need to know these simple features because a description in the exam will actually point for you to the cause. So it is watery and it is offensive. It's smelly. And then Entamoeba histolytica, the blood here is the diarrhea is actually bloody. And then there may be tenesmus. Okay. A feeling as though you want to pass through, but then there's nothing that is coming out. And there is usually no fever. So parasitic causes are less than will cause less than 10% of the causes. And now they present there's going to be watery stool, which is greenish, frothy stool. There's also going to be agents of passing stool after meals, like someone just eats and then they feel like just going to the toilet, low grade fever, and it's differentiated from the viral gastroenteritis by a protracted course or history of travel to an endemic area. So someone went to an area, they came back, and then they had this diarrhea. All right. There are actually also some substances or medications that are associated with diarrhea. For example, stimulant laxatives like Senna, Bisacodyl. These drugs are given if someone has got constipation so that they can actually pass the stool. Even antacids, like those that are they have got osmotic effects. You use these for peptic ulcers like magnesium, okay, because it can't be absorbed, it will start pulling water towards itself. Even prokinetic agents, these are again agents that increase peristalsis. They're also used in the treatment of constipation, like metoclopramide, beta, bethanical, Cisapride, and also measles, mumps, rubella vaccine. So this vaccine is also associated to causing diarrhea, though the explanation is not really clear. Right? Thyroid hormones can cause diarrhea, chemotherapy, heavy metals, organophosphates. Okay, this is because the parasympathetic is a rest and digest. Okay, and it actually increases GI motility. So organophosphates are parasympatomimetic. So these are they have got cholinergic effects. They stimulate motility. Diuretics also an unknown called digitalis, causicin, indomethacin, which is a prostaglandin synthesis inhibitor, and then theophylline, which also increases peristalsis. This table is just showing the syndromes that are associated with community acquired gastroenteritis. You have got acute watery diarrhea, dysentery. It's a good table that you can just get to look at. You are going to see the signs and symptoms, the pathogenic mechanism, and also the examples of pathogens. So, what are the causes of acute diarrhea at different age groups? We've already talked about the causes. Okay, by far the commonest cause in the young is the rotavirus. By far the commonest, followed by the bacteria and protozoas. You also have food poisoning. It can also cause diarrhea. But then when you are taking history, you should ask questions more to find out if really it was food poisoning. Okay, we'll talk about that. Systemic infections, for example, otitis media, even UTIs can cause this. Antibiotic associated diarrhea also because of Clostridia difficile. Even overfeeding can cause diarrhea. Those are the common causes of food diarrhea. The rare causes include primary disaccharide deficiency, Hirschsprung's toxic colitis, adrenocongenital syndrome, neonatal opiate withdrawal, toxic ingestion, hemolytic uremic syndrome, insufficient hypothyroidism, appendicitis, and such. So, what are the differential diagnoses of diarrhea? So, in an infant, by far gastroenteritis is the most common. Systemic infection like UTIs, otitis media, antibiotic associated, okay, Hirschsprung's disease. In a child, again, food poisoning it comes also in play. Systemic infections, antibiotics. In the adolescents, food poisoning again, even antibiotic associated, and hyperthyroidism. So, what is a general approach to managing a patient that has got diarrhea? So, you have to take a history. Okay. So, I need to find out the onset of the diarrhea so that you can put it, is it the mild, moderate, or severe? The frequency and the character of the stool. Okay. How many motion is this person having in a day? Okay. The onset is, did this diarrhea start immediately? It was gradual. And if it was immediately, was it just after eating, or maybe someone just started like that? Because we want to associate it. If it was immediately after eating, maybe it was poisoning. And in that case, you again need to ask, was there anyone else in the family who was affected, who also had diarrhea? Because if after eating you develop diarrhea and then another one has developed diarrhea, that might be food poisoning. So it's very important for you to take a very good history. The frequency of the diarrhea is also very important. How many times is this person going to the toilet? And the character of the stool. Is it bloody? Is it watery? In cholera, the diarrhea is described as a rice water. Rice water is going to be looking, it's just watery, but then the way the water for rice, when you're washing rice, looks, okay, to be looking white, that whitish, like white, not just the clear one. Okay, so it's important to understand the character of the stool. Is there mucus there? Okay, estimate also the stool volume. How much was the stool? How much? Can you estimate it? What can it feel? Okay. Was it also the consistency of the stool? Was it hard? Was it soft? You need to tell also. Remember, diarrhea is the passage of loosey stool. Okay, so loosey stool is the stool that can fill up a container. Was there blood in the stool? It mentions that. Was there also vomiting? Was there blood, mucus, or fever? Because that can actually point to an infection. Does this person has a fever? Are there B symptoms or constitutional symptoms? Fever, weight loss, malaise. Okay. And then the dietary factor should also be investigated. A list of medications that have been recently used, because some medications can actually cause diarrhea. Okay. Factors that seem to worsen or improve the diarrhea should also be determined. So vomiting and diarrhea developing within hours of food ingestion can actually mean that this person ate some toxins. Okay, some would have taken toxins in the food. Okay, so also find out about the indicators of dehydration. When someone has got diarrhea, they might be dehydrated. And this is one of the important things that you need to determine in a pediatric patient. Dehydration, very, very important. So the urine output and the color. Okay, so for children that are dehydrated, usually the urine output is going to be decreased less than 3 times in a day. And normally for children, especially those that you put on diapers, you might not tell that it's less than 3 times. So you just look at the diapers. Are they wet? Are they dry? Okay, if they are dry, it means that this one is dehydrated. They are not passing stool. Okay, again, when the child is crying, are they producing any tears? Very, very important. That is another red flag to dehydration. Also, fluid intake. Okay, poor drinking or refusal to drink means that this one is really, really dehydrated. And then you have got those that are so eager to drink, so eager to drink. So you need to know this. Eagerness to drink water is because they don't have water, so they want to drink a lot in the body to replace what is not in the body. And so that means they are dehydrated. But then if they reach to a point where they don't even want to drink, refusing to drink water, just know that that has gone severe. Okay, that has gone severe. All right. And then you have got weight loss. Rapid weight loss is a strong objective marker for fluid deficit. You have got other systemic symptoms that marks dehydration or basically AGE, uracea or dysuria. Okay, pain during urination. This can point to infection which is outside the GIT. Okay, it might not be dehydration per se, but it is just a problem outside the GIT. And then hematuria, when you find that there is actually blood in urine or oliguria, it can actually raise a suspicion for hemolytic uremic syndrome if someone is passing blood in the stool or they are not even passing out blood. If you have got convulsions or severe abdominal pain, that means that that is a Shigella infection because diarrhea plus seizures that points you to Shigella. Okay, and then if this person is in the hospital, okay, they're in the hospital and then they're having diarrhea, that might be nosocomial diarrhea gotten from the hospital, maybe drugs and such. If a family member is also affected, that might be food poisoning. If someone went out and then they came and then they have got a travel history, they develop this diarrhea, it might mean a risk of pathogens not endemic locally. Maybe they went to get it somewhere, like parasitic infections. Vaccination history. You look at the vaccination as if they've been vaccinated against rota. Okay, if not, that might be a problem. You need to make sure they are vaccinated. Nutritional status. Is this patient malnourished? Because malnourished children dehydrate faster. Okay, and then for the physical exam, some things that you want to do is assess for dehydration. There are things that you look at to tell that this child is actually dehydrated. Okay, for example, urine output, you look at the urine output. If it is less than 3 times in a day, or is it dark urine, the absence of tears when crying, dry mucous membrane. So you look at the mouth, are they dry? Okay, sunken eyes. Are the eyes sunken? Are they going inside? And then delayed capillary refill time. If it is more than 3 seconds. Is this patient lethargic or irritable? You just touch it, they are really crying a lot. And then you also look at the anterior fontanelle. Is it depressed? Please, these are very, very important features to assess for dehydration. Okay, you also look at the weight. Okay, because they can actually be weight loss. And then signs of extra GIT infection, for example, uracea, dysuria, fever, cough. You also do an abdominal exam. Okay, there can be distension when you do an abdominal exam. Okay, so if there's distension, it can suggest maybe there is paralytic ileus, like the GIT is not actually, there's no motility, things are not being pushed forward. Okay, things are not being pushed forward, and that can actually cause this ileus. Or maybe there's an obstruction, so that's why there's a distension, so things cannot be pushed forward. Or maybe just a severe infection. So what happens that when there is dehydration, like someone that has got diarrhea, there will be hypokalemia. Okay, because you also lose the potassium, and that will lead to paralytic ileus because contraction is affected when you don't have potassium, and that leads to abdominal distension. So I should be able to explain how paralytic ileus comes about in diarrhea. There can also be tenderness, which can be, if the tenderness is localized to a point like on the McBurney's point, that can be appendicitis. Tenderness can also mean intussusception or Shigella. Okay, tenderness is basically pain that is felt when you are palpating. And then the quality of the bowel sounds. Hyperactivity can be seen in gastroenteritis, but it is absent in actually ileus. Okay, so you'll be able to hear a lot of bowel sounds. In ileus, there is no motility, so you might not be able to get any bowel sounds. You can also do a rectal exam. You look at the blood in, is there blood in stool? Okay, it might mean dysentery. Do you have large fecal mass? Okay, a large fecal mass might mean constipation. And then anal sphincter tone, you feel also for the sphincter tone. Maybe it is a neurological problem. Someone has got a problem with the nervous system, so the sphincters are so tight. That's why they can't even pass a stool. Okay? Or maybe the sphincter is so weak. That is why they're always passing stool like that. So it can mean a problem. So the clinical assessment for dehydration, when you're assessing for dehydration, you have got no dehydration, you have got some dehydration, and then severe dehydration. That's how you classify dehydration: no dehydration, some dehydration, and severe dehydration. So in no dehydration, the patient is usually well, the eyes are normal, the tears are present when their child is crying, the mouth and the tongue are moist, it's not dry. The child, they can drink normally, okay, is not really thirsty. And then when you do a skin pinch, we call that a skin tagger. Like you pinch the skin, you pull it up, it can go back quickly to normal. Okay, so there are basically no signs of dehydration. So for the treatment of no dehydration, we use what we call the plan A. And then for some dehydration, when you look at the condition, the child is usually restless, irritable, you just touch them, they are crying. The eyes are sunken, the tears are absent. The child is crying, but then they are not tears. The mouth and the tongue, these ones are dry. And then the child has got this eager to drink. He just wants to drink water, just says the bottle wants to drink. Okay, that eagerness. And then for the skin pinchy, like when you look at the skin tagger, okay, you pinch the skin, it is going back slowly. So if the patient has two or more signs, then there is some dehydration, two or more signs. So here you are going to weigh the patient, and then you see the weight, if the child has really lost some weight. And then of course, depending on the loss of weight, you can also help to classify that. But for some dehydration, you use what we call the plan B, which we'll of course discuss when we talk about dehydration. And then for severe dehydration, the condition, the patient is actually lethargic or even unconscious and floppy. They can't, the hands are so floppy. When you get them up, they can't stand, that's being floppy. The eyes are very sunken and dry. The tears are absent, and then the mouth and the tongue are very dry. Thirsty, the child drinks poorly or is not even able to drink at all. The skin tagger, when you pinch the skin, it goes back very slowly. Okay? If patient has two or more signs, that is going to be severe dehydration out of this that you can see. So for management, use what we call the plan C. Okay? So children who are at increased risk of dehydration and need special attention includes infants, those that are under 6 months of age, or those born with low birth weight. Okay, if they have passed, even those that have passed greater than 6 diarrhea stools in the previous 24 hours, if they have vomited 3 or more times in the previous 24 hours, vomiting again is very, very important. Because imagine someone is having diarrhea and also vomiting, so they are losing water from two ends, they'll be really, really dehydrated. Okay, if they have been unable to tolerate, okay, like you give them food, they can't take it by mouth if they have malnutrition. So these ones need special attention, very, very much. Okay, very important, take note. So these are the signs we are talking about that you need to look for. Decreased level of consciousness, sunken eyes, dry mucous membranes, eyes sunken and tender. They also be having tachycardia because we don't have enough water in the body, so the heart is bumping very fast. Okay, prolonged capillary fill time greater than 3 seconds. Pale or mottled skin, hypotension. Okay, so someone has got tachycardia, the heart is beating fast, but then there's also hypotension, you have got little fluid in the vessels. Okay, tachycardia, and then you also have weak peripheral pulses. So if you feel for the radial pulse is going to be weak. Reduce skin tagger, like when you pull the skin. Okay, sudden weight loss, reduced urine output, even cold extremities. Again, these are basically the other signs, okay, which you can just look at this table. So for the management, we said that you use plans, right? You have got the plan A, the plan B, the plan C. But of course, we'll discuss this much in detail. So for plan A, this is basically a child who has got diarrhea but doesn't have any signs of dehydration. Okay, so you can treat them at home. Basically, I recommend giving the child the ORS. Okay, giving the child ORS. But in case you tell the mother, in case you see some danger signs, quickly bring the child to the hospital. For example, if the diarrhea continues beyond 3 days, if there's an increase in stool volume or frequency, there's repeated vomiting, there's increased thirsty, increased irritability, refusal to feed, a fever or blood in stool. And then for plan B, this one is treated, these children are treated in the hospital. Okay, you give them some ORS here also. All right. Yeah, so that is what happens. And then you also have the plan C, which is also treated in the hospital. But we'll talk about the details of these plans when we discuss dehydration in just the next class. All right. What are the complications of gastroenteritis? It includes dehydration, as we've said. Shock can also come in. Okay. This is basically hypovolemic shock because the child will be losing water. Okay. So it can be either hypovolemic shock or it can be septic shock. Septic shock because one of the causes of diarrhea can actually be the gram negatives, the bacteria. And these bacteria, once they go in blood, they can cause sepsis, and that can lead to septic shock because the body will now be responding and then dilating the blood vessels and all these problems happening. So clinically, once a patient has got shock, there'll be decreased peripheral perfusion. So there'll be skin mottling. The skin will appear white when you press it. Okay, these are some things you want to do during your physical exam. Okay, that skin mottling, it will be appearing white. That means that there's actually a decrease in volume of water. And then capillary refill time is greater than 2 seconds. Cord extremities also, there'll be decreased vital organ perfusion. If there's little blood going to the brain, the child is lethargic. If there's little blood going to the kidney, there will be oliguria. Okay, there will also be hypotension and the thready, weak pulse. There can also be acute renal failure as another complication of AGE. And the acute renal failure is because you have got little volume, so that hypovolemia leads to reduction in the renal blood flow. Okay, when there's a reduction in the renal blood flow, that actually leads to renal failure. We call that as a pre-renal cause because the cause was before the kidney. Okay, basically a problem with the blood is decreased. And then even untreated pre-renal failure can actually lead to tubular necrosis. There's no blood going to the kidneys, that leads to the necrosis, and that leads to intrinsic renal failure. Okay, clinically the child is going to have oliguria or even anuria. They're not passing any urine. Even acidotic breathing, they're breathing very fast, rapid, and deep breathing. There can also be metabolic acidosis because of the loss of bicarbonate in stool, or even the same acute renal failure on top that can lead actually to metabolic acidosis. So clinically for the metabolic acidosis, there will be acidotic breathing, disturbed consciousness, arterial blood gas. And these are things that you want to be looking for when you're doing your physical exam. Okay? You look at the kind of breathing for the child. How is the child breathing? Is the child conscious? For the investigations, these are also investigations you want to do for someone that has got AGE. You look at the blood gas, arterial blood gases. The pH is low because of acidosis. Partial pressure of carbon dioxide is low. The partial pressure of bicarbonate is also low. Right? For the electrolytes, also there can be a disturbance. There will be hypokalemia where specific potassium is less than 3 milliequivalents. So if someone has got hypokalemia, you are going to have apathy, okay, disturbs consciousness, arrhythmias, abdominal distension because of paralytic areas, even atony because of hypotonia. The child is floppy and such. Hypocalcemia can also happen, which leads to tetany, basically in a contracted state. There can also be hypo or hypernatremia, which can lead to convulsions. And this convulsion can actually come because of hypoglycemia, hypernatremia, hypocalcemia, even CNS infection, for example, meningitis, encephalitis, because of Shigella or those other viruses that can actually produce toxins that go to the brain, which can lead to convulsions. There can also be bleeding. Okay, bleeding can also happen. For example, what are the possible causes of this bleeding? They can be disseminated intravascular coagulopathy. If someone has got shock, right, or maybe sepsis or acidosis, those can lead to disseminated intravascular coagulopathy. Even intussusception, okay, part of the intestine actually invaginates, goes into the distal end of the intestine. That's what we call intussusception. Renal vein thrombosis can also get to happen. Okay, so for DIC, how it presents is that someone is going to be having bleeding, even skin gangrene. For interception, there will be attacks of abdominal pain, so the child will be screaming, okay, vomiting with constipation. Okay, there will be sausage shaped abdominal mass when you actually do even an x ray. So, another complication is actually persistent diarrhea, which can lead to malnutrition. So, some associations that we need to know with diarrhea: the most common cause of diarrhea is viral, specifically the rotavirus. Traveler's diarrhea is caused by the enterotoxigenic E. coli. Okay, hemolytic uremic syndrome is caused by enterohemorrhagic E. coli. We call it the O157H7. You need to know this number. O157H7. Even Campylobacter jejuni can also cause a hemolytic uremic syndrome. Acute abdomen can be caused by Yersinia campylobacter. Basically, this is pain in the abdomen. Okay, pain. There are many differentials of acute abdomen, including appendicitis, ectopic pregnancies, but depending with the age. Okay, hemolytic uremic syndrome plus Reiter, that means Shigella or Campylobacter. Seizures is Shigella. Okay, GBS, that is Guillain-Barré syndrome, that is Campylobacter jejuni. We call this as ascending paralysis. So someone has got paralysis starting from the lower limb going upwards. Salmonella is going to cause bloody positive blood cultures, hemoglobinopathy, splenectomy, antibiotic associated, that is Clostridia difficile. Okay, so those are some of the ones we need to take note of. So for the workout investigations that you do in someone that has got acute gastroenteritis, so for you to find out the cause, you can do a stool analysis. Stool analysis, you can do an ACOUT blood test. Okay, ACOUT means hidden, so you look in case there is hidden blood in the stool. You look at the fecal leukocytes, which can suggest an invasive bacterial infection. Rotazyme test. This is basically for the rotavirus antigen, which is basically a protein of the rotavirus. Even ovan parasite, in case you can see them in the stool. Okay, stool culture can also be done for bacterial pathogen like Salmonella, Shigella, E. coli. For complications, which is more important, you can do routine labs. Okay, so for the labs, you can do the blood urea nitrogen, creatinine to assess for the renal function. Electrolytes also, they are going to be disturbed. For example, sodium, potassium, you can have hypokalemia, hyponatremia, calcemia and such. Blood gases also check for metabolic acidosis, coagulation profile, prothrombin time, partial uh, activated partial thromboplastin time, platelets to just evaluate for bleeding tendencies, because DIC can actually happen in AGE. Other investigations which will be guided by the clinical suspicion includes the abdominal ultrasound in case someone is presenting with so much abdominal pains and you're thinking maybe it can be an abdominal obstruction or maybe a perforation or interruption. Okay. The way you manage acute gastroenteritis, you need to make sure that you look at the principles of management. Very important to know the principles. Why are we trying to manage these patients? So rehydration, you want to rehydrate them, okay, and maintain hydration. Ensure that the child is having adequate feeding. They need to be breastfed. Also, oral supplementation of zinc. Please, zinc is very important in acute gastroenteritis. For children and also for adults, it's very nice. Okay. Early recognition of danger signs and treatment of complications. Very important. So treatment is actually usually supportive, as we've said, rehydration, preventing dehydration. If signs of dehydration are mild or absent, the child can be managed at home. Breastfeeding should be continued. If the baby is on bottle, give ORS and not dilute. And not dilute the formula. Okay, make sure you give ORS. ORS is very important in dehydration. For the antidiarrheal drugs or antimotility agents, you can give loperamide, Lomotil, these are antidiarrheals. And also those drugs to stop vomiting and emetics, though they barely have any role to play here. Okay. Even the antidiarrheal drugs, you normally don't give them. You normally want to just uh, continue feeding. You give the ORS, even zinc. Ondansetron can also be administered. Ondansetron is actually an antiemetic. It stops vomiting. This is just to reduce on the vomiting. Zinc is very important. Okay. So for antibiotics, they are not normally given in someone that has got acute gastroenteritis. Okay, even if there is a bacterial cause. They are often indicated, but of course you only give antibiotics if there is an indication. For example, those with severe disease or bacteremia, suspected or confirmed sepsis, extraintestinal spread of bacterial infection, for example, meningitis. Okay, you're suspecting meningitis. High risk patients like the malnourished or immunocompromised, even for specific bacterial or protozoal infections. Okay, you can give these specific bacterial causes. For protozoal infections, you give antiprotozoal agents. For Salmonella gastroenteritis, if the child is less than 6 months, you can also give. So antibiotics, you don't give them in E. coli, the one or the enterohemorrhagic or 15787. These will increase the risk of hemolytic uremic syndrome. And complicated salmonella enteritis, you don't give also because they'll prolong the shedding of the bacteria, like the bacteria will not be removed from the body. Okay, so for the treatment, you give fluids. Okay, avoid dehydration by plenty of fluids, so you give ORS. Very, very important also to take note of. Okay, so for you can also give food-based fluids for those that are greater than 6 months. Besides you just giving the ORS, for example, rice water, soup, yogurt drinks. Avoid hyposmolar fluids. Okay, sugars, drinks, carbonated drinks, and such. Feeding also should be done to avoid malnutrition. For example, continue breastfeeding for infants who are greater than 6 months. You give mashed potatoes, cereals, okay, even but likes bananas, apple juice, rice, even toast. And then follow up and medical advice. So if there's no improvement in 3 to 5 days, the mother should come back to the hospital. If there's a presence of warning sign, the mother should come back to the hospital. The warning sign you can use bloody fever. So the B there is a bloody motion. The F is high fever, is eager to drink, okay, and then vomiting, excessive water emotions, refusal to take oral fluids. So these are warning signs the child should be brought to the hospital. Okay. Gastroenteritis with dehydration, you're going to use if there is dehydration, because this management is actually for no dehydration. So this is known as the plan A, where you basically give ORS, okay, fluid therapy, feeding, and then also follow up. You only follow up if warning signs begin to show up. But if there's dehydration, use the plan B and the plan C. Okay, antibiotics you normally don't give them except there's an indication. You can also give anti-parasitic drugs like metronidazole. For Clostridia diffuse, I remember I said that this is causes the antibiotic associated uh, diarrhea. Clostridia diffuse also causes what we call pseudomembranous colitis. You need to know that. Okay, it's associated to antibiotics. You also treat the complication like acute renal failure. This one can respond to rehydration, just rehydrate. If someone has got hypocalcemia, give them calcium gluconate. If they have got hypokalemia, add potassium to the IV fluids. If they're having convulsions, give anticonvulsants like diazepam. You also give additional therapy like probiotics, okay, for non-pathogenic bacteria, and then give zinc. So to prevent gastroenteritis, rotavirus vaccination very important. Hygienic measures, proper weaning, okay, weaning basically introducing other feeds. Don't just stop breastfeeding the child, okay. So promote exclusive breastfeeding for the first 6 months and continue during illness. Okay, very important, exclusive breastfeeding. So this table is just showing the plans. Plan A on how to treat the diarrhea. You treat it at home, basically give fluids, teach the mother on how to mix and give ORS. Okay, show mother how much fluid to give in addition to the usual fluid intake. And then give zinc supplements. Okay, continue feeding and tell the mother when to return when they see the warning signs. So for the plan B, this is where someone has got some dehydration. Here you are going to give extra fluids, give zinc, continue feeding. Uh, Also ask them, tell the mother on how to know when to return to the hospital. Basically to the plan A now you just add other things. Okay, we'll discuss the details of the plan B as we get to talk about dehydration. And then plan C, that is now severe dehydration. You can also manage it and we'll talk about the details of the management. So ORS is a very important one that should be given. You need to know the components of ORIs, very, very important. So usually what we use is the low osmolarity ORIs formulation, which is recommended by the WHO. You need to know the ingredients and the amount. So we have got sodium chloride, which is 2.6 grams, okay, per liter of ORIs. Glucose is 13.5 grams per liter. And then you have got potassium chloride, which is 1.5, and then you have got the trisodium citrate, which is 2.9. You need to know the composition. Okay, the ingredients, again, you need to know the concentration. This is actually the weight. It's also the concentration is grams per liter. Okay, so in sodium chloride you have got sodium is 75 millimoles per liter. In this glucose, it's actually 75 millimoles per liter. The potassium is 20, The chloride is 65 millimoles per liter. The citrate is actually 10 millimoles. So the total osmolarity, okay, is 245. So the osmolarity of this ORS is lower than that of plasma. What are the benefits of ORS? It will replace the water and the salt which is lost during dehydration. It will reduce dehydration and the need for hospitalization. It will decrease the severity of diarrhea and vomiting. It will decrease the duration of the illness. Okay. The way you prepare the ORS, you wash your hands, pour all the ORS powder into a container which is having the capacity of 1 liter. 1 liter. Okay. Measure 1 liter of drinking water, okay, which is boiled and cooled. So you first boil the water and then you cool it. So measure 1 liter of drinking water. You pour now in the container where you had actually put your ORS sachet, and then you stir well until the powder is mixed thoroughly. It is easy. You need to know how to prepare. These questions have come. Okay, they do come. In case you don't have that, you can just prepare a simple recipe at home. If you don't have the ORS sachets, okay, you just use 6 level teaspoons of sugar, which is about 30 grams, okay, and then half level teaspoon of salt, which is about 3 grams. So sugar, 6 level teaspoons, half level of teaspoon of salt, which is about 3 grams, and then dissolve in 1 liter of clean water. Okay, that will give you the ORS. So it's important to understand that. And then we talked about zinc also. Zinc is very, very important. So zinc is a micronutrient which promotes immunity. It's an important antioxidant, okay, which preserves cellular membrane integrity. It promotes the growth and development of the nervous system. It is also a rich source. A rich source of zinc is actually of animal origin, for example, meat and fish. Zinc is also present in nuts, seeds, legumes, okay, whole grain cereals, but also uh, other contents. Though you have got a high fitted content of these foods, they can actually interfere with absorption, like these same foods that we've talked about. But generally, that's where you can find the zinc, like in the cereals. Zinc cannot be stored in the body, and zinc is excretion is through the GIT. Okay, and it will be increased during episodes of diarrhea. So young children who have frequent episodes of diarrhea and have diet low in animal products and high in fitted rich food are most at risk of zinc deficiency. Remember, high fitted contents will actually interfere with its absorption, the absorption of zinc. So if a child has got diarrhea, and then they're not taking animal products where you can find zinc, and then fitted rich foods which actually interfere with zinc absorption, they're actually going to be more at risk. How does zinc help? Zinc reduces the fluid and this salt loss, okay, in stool by improving mucosa permeability, okay. And then zinc will accelerate regeneration of the mucosa. It actually involves in what we call re-epithelialization, because these causes of diarrhea actually destroy the epithelium. So zinc will promote re-epithelialization of the regeneration of the mucosa. It also increases the levels of brush border enzymes. It will enhance cellular immunity. Okay, it will also high levels of secretory antibodies, like it will increase the antibodies, which will protect you, of course. It will also improve the absorption of ORS. It will reduce the severity and duration of the illness. It will reduce the need for antibiotics. It will reduce the chances of complications. Okay, so a full dose for 14 days will protect against diarrhea and pneumonia for the next 3 months. You see how good it is. And it will also act as a genotonic it will improve appetite and promote growth. So please, it's a manner for you to know the mechanisms of action of zinc and what are the benefits of zinc. For the mechanism of action, regeneration of the mucosa, increase the levels of brush border enzymes, enhance cellular immunity, increase the antibodies, increase the absorption of ORAs, to reduce the severity and the duration of the diarrhea. It will reduce the need to use antibiotics, the need to use for the complications to come in. So please, it's important you know that. Okay, very, very important. How do you prevent diarrhea? Proper nutrition, adequate sanitation, exclusive breastfeeding for the first 6 months, and then wash your hands, wash the containers, clean the environment. Vaccination against rota, very, very important. So that is about AGE. So get to try out these questions. Okay. So that is that, and that is where we end for this class. Thank you so much for being present. Have a blessed day.